everybody and welcome to tonight's special episode of The Footy Show, here live at Adelaide Oval. Tonight here we have with us the Adelaide Football Club to talk about their win. But first, let's talk about Robbie Gray's ACL injury from last week. If you didn't catch what happened with the Pies, here's what happens.
He's in a lot more pain than Luke Ball. That could be a broken leg.
Boy, does that look bad.
Did he dislocate his knee, did he, Jared?
Looks to me just like he hyperextended.
Oh, that's good.
And he is critical to their chances of fighting their way up the ladder in 2012.
What a painful injury, unfortunately, for the poor boys. Now to improve upon the description of what the commentators gave us last week, here we have Port Adelaide Football Club's physiotherapist, Jess.
Thank you. Hi Caitlin, thank you for having me on the show. In simple terms, what has happened during this injury is...
Robbie Gray has jumped up to mark the football, decelerates from the jump and full speed lands onto the ground. The sudden impact causes lateral rotation of his knee during a hyperextended position, causing his knee to give out and his ACL to tear due to the sudden extreme force.
Thanks, Jess. Also here with us today is Dr. Emma, the specialist sports doctor for Port Adelaide Football Club. For those of our viewers who are interested in sporting injuries, definitely stay tuned because after the break, she's going to give us some more in-depth information about Robbie's knee trauma.
Are you struggling with anatomy? Well, MSK is here to help. Follow us for all of your anatomy needs.
Hello everyone. Now, injuries affecting the lower limb are very common in contact sports such as AFL. In fact, hamstring, hip groin injuries and ACL injuries are consistently reported year after year as the three most common non-contact injuries in an AFL season. But I'm not here to talk about leg injuries, so let's just focus on the knee joint and see why Robbie Gray will miss the rest of the AFL season.
Located between the body's two longest lever arms, the knee functions to bear weight and aid in locomotion. However, when an AFL player pivots, jumps, lands and performs quick stop-start manoeuvres, a considerable amount of stress and torsion is placed on the structures that make up this complex hinge synovial joint. As you can see, the knee is formed by articulations between the femur, tibia and patella. Resultantly, the knee consists of the tibiofemoral and patellofemoral joints. Also take notice of the head of the fibula, which does not contribute to either of these joints but does serve as an attachment site for muscles and ligaments, which will be discussed later. The tibiofemoral joint is composed of articulations between the inferior aspects of the medial and lateral femoral condyles and the corresponding superior surfaces of the medial and lateral tibial condyles. Importantly, hyaline cartilage lines the ends of these two articulating bones to provide a smooth surface for movement. Important bony landmarks on the distal end of the femur include the intercondylar fossa found posteriorly between the two condyles and the non-articular medial and lateral epicondyles. Now, lying medially, the tibia bears much more body weight than the fibula, and with regards to the tibiofemoral joint, the bony features of the superior aspect of the tibia are the most important. These features are collectively referred to as the tibial plateau. Key features of the tibial plateau include the articular surfaces of the tibial condyles, which are separated by the intercondylar region. This region is divided into an anterior and posterior fossa by the intercondylar eminence or spine. Furthermore, on its anterior surface, the tibia has a large roughened area of bone known as the tibial tuberosity. Moving on to the patella, this large sesamoid bone articulates with the patellar surface of the femur to form the patellofemoral joint. The patella is enclosed within the quadriceps tendon, which is continuous with the patellar ligament. The patella serves many functions, including protecting the internal joint structures from the grinding forces of the quadriceps tendon and creating an improved angle of pull for the quadriceps muscles. As one of the most complex diarthroidal joints in the body, the knee contains structures that are consistent with all synovial joints, as well as more specific accessory features. Characteristic of all synovial joints is the joint capsule, which in the knee encloses the articulating ends of the femur and tibia. The joint capsule consists of an outer fibrous layer and an inner synovial membrane, which secretes synovial fluid into the joint cavity. Likewise, all synovial joints have supportive extracapsular ligaments that reinforce the joint and strengthen the fibrous capsule. In the knee, the two most important extracapsular ligaments are the lateral and medial collateral ligaments. Preventing tibial adduction, the lateral collateral ligament connects the lateral epicondyle of the femur to the head of the fibula, whereas the medial collateral ligament runs from the medial epicondyle of the femur to the medial surface of the tibia and prevents tibial abduction. The knee also contains two specialized cartilage structures. Known as the medial and lateral menisci, these semilinear bands of fibroid cartilage cover the periphery of the tibial condyles to stabilize the knee and function as shock absorbers. These two menisci can move slightly and are held in place by various small ligaments, such as a transverse ligament of the knee anteriorly. The tibiofemoral joint is further stabilized by two intracapsular ligaments. These are the posterior and anterior cruciate ligaments. The PCL runs from the posterior intercondylar fossa of the tibia to the medial femoral condyle, whereas the ACL connects the anterior intercondylar fossa of the tibia to the lateral femoral condyle. Crossing over one another within the knee joint, the PCL limits posterior displacement of the tibia, whereas the ACL limits anterior displacement of the tibia as well as hyperextension and lateral rotation. Another important soft tissue structure is the infrapatellar fat pad, which helps to protect the underlying structures and functions as a shock absorber. And finally, there are more than 10 bursa located between the knee's ligamentous, bony and muscular structures. Because the tibiofemoral joint is a modified hinge-type synovial joint, its range of movement is primarily limited to flexion and extension. However, when the knee is flexed to 30 degrees or more, small amounts of internal and external rotation can occur. Nonetheless, the tibiofemoral joint is classified as uniaxial as this rotational movement is not significant. In terms of planes of motion and axes of rotation, knee flexion and extension movements occur in the sagittal plane along the mediolateral axis of rotation, whereas any internal or external rotation occurs in the transverse plane and has a longitudinal axis of rotation. Because the ACL acts to limit knee hyperextension and rotational knee movements, excessive combined motion in both the sagittal and transverse planes during sudden deceleration, such as when Robbie's leg landed onto the ground, demonstrate that non-contact ACL injuries can result from multiplane loading of the ACL during weight-bearing activities. Now, the muscle group that extends the knee is located in the anterior compartment of the thigh and is known collectively as the quadriceps. Laterally, we have the vastus lateralis muscle. Medially, there is the vastus medialis muscle. Located deep to rectus femoris and in between vastus lateralis and medialis is vastus intermedialis. The final and most superficial quadricep muscle is rectus femoris. The quadriceps muscles work together to pull the patella superiorly, which in turn pulls the leg into extension at the knee by their attachment to the tibial tuberosity via the patella tendon. Furthermore, the group of muscles primarily responsible for flexion of the knee are located in the posterior compartment of the thigh and are known as the hamstring muscles. Located laterally is biceps femoris, which has both a long and a short head. The first hamstring located medially is semimembranosus. Then we have semitendinosus, which is superficial to semimembranosus. Additional muscles, such as sartorius, also contribute to knee flexion. Gracilis is another muscle that contributes to knee flexion, although it is primarily a hip adductor. Although it is located in the lower part of the leg, the gastrocnemius muscle also contributes to knee flexion. And finally, the popliteus muscle, which is involved in knee flexion but primarily internally rotates the tibia to unlock the knee at the initiation of flexion. The knee will not otherwise allow rotation unless it is flexed more than 20 to 30 degrees. Therefore, the internal rotators of a flexed knee are semimembranosus, semitendinosus, sartorius, gracilis, and popliteus, whereas biceps femoris is the only muscle that produces external rotation of a flexed knee. Arterial supply to the tibiofemoral joint is from branches of the femoral and popliteal arteries. At the knee, the popliteal artery branches into the medial and lateral superior genicular arteries and medial and lateral inferior genicular arteries, which form anastomoses around the anterior aspect of the knee. An additional branch of the popliteal artery is the middle genicular artery, which supplies the synovial membrane and cruciate ligaments from the posterior aspect of the joint. Venous drainage from the deep layer of the knee occurs via the popliteal vein, whereas venous drainage of the superficial layer of the knee occurs via the short saphenous and great saphenous veins. The tibiofemoral joint is innervated by several nerves of the lumbosacral plexus that travel past the knee. These include branches of the tibial and common fibular nerves as well as the femoral nerve. The femoral nerve supplies motor innervation to the muscles of the anterior compartment of the thigh, which primarily extends the knee. Cutaneous branches of the femoral nerve also supply sensory innervation to the anterior surface of the skin surrounding the knee. The tibial and common fibular nerves are the two divisions of the sciatic nerve. The tibial nerve supplies motor innervation to the muscles of the posterior compartment of the thigh and leg, which flex the knee, whereas the common fibular nerve supplies motor innervation to the short head of biceps femoris, which also flexes the knee. And finally, the posterior femoral cutaneous nerve, as well as cutaneous branches of the tibial and common fibular nerves, all supply sensory innervation to the posterior surface of the skin surrounding the knee.
Wow, so Dr. Emma, is there any possibility that Robbie suffered from any bleeding or nerve damage as a result of his injury?
Well, since the knee joint is surrounded by an intricate network of blood vessels, any trauma to the joint such as that caused by an ACL tear is likely to cause bleeding. In fact, a common symptom of an ACL tear is swelling, which is a sign that there is blood in the joint space. As for nerve damage, it is possible that the abnormal lateral bending of Robbie's knee upon landing may have compressed the nerves that run along the lower limb, particularly those on the lateral side, such as the common fibular nerve.
Is it dangerous for there to be any bleeding in the joint space? What can be done to reduce the swelling?
In most cases, bleeding into the joint space can only become dangerous if it is left untreated. For an ACL tear, the best way to avoid any further complications and to reduce the pain and swelling is to follow the RICE regime, which is rest, ice, compress and elevate.
And finally, what about nerve compression? What are the potential implications of that?
Signs of nerve damage include numbness, tingling and muscle weakness. With regards to the common fibular nerve, an inability to dorsiflex the ankle, invert the foot and extend the toes is a sign that there may be damage. If Robbie was to experience any of these symptoms following his incident, it would be imperative that he discuss this with his doctor.
Of course. Now, what are the clinical presentation of ACL injury and how will Robbie's movement be affected?
Well, patients commonly report hearing or feeling a pop at the time of injury, which is immediately followed by intense pain and some swelling. Furthermore, upon examination, the injured knee has a decreased range of movement and is very unstable.
Specifically, the knee will often buckle with movements that occur in both the sagittal and transverse planes where body weight is placed on the affected leg, such as squatting, pivoting, stepping sideways, changing direction, and walking on an uneven surface. Furthermore, a Lockman's test can be carried out to assess the integrity of this ligament because when the ACL is damaged, excessive anterior tibial translation in the sagittal plane occurs.
Wow, what a poor guy. So, Dr. Emma, we know that Robbie underwent surgery at the beginning of this week to repair his ACL. Can you explain to us why Robbie required a knee reconstruction? Do all ACLs require surgery?
So the most distressing thing about ACL injuries in particular is that this ligament undergoes limited healing after damage.
And therefore, although mild ACL injuries where the ligament is stretched or partially torn only require physiotherapy and bracing, Robbie required reconstructive ACL surgery because his ACL injury was severe, meaning that the ligament is completely torn. Having surgery gave Robbie the best chance at returning to elite football by restoring his knee's strength, stability and range of movement. Specifically, the surgery that he underwent utilises an arthroscope to remove the damaged ACL and replace it with a graft of a healthy tendon. These grafts can be acquired from a donor cadaver or from one of the muscle tendons that surround the patient's knee.
Yes, hopefully Robbie makes a quick and speedy recovery. Speaking of time, how long can you expect Robbie to sit on the sidelines for?
Well, depending on Robbie's dedication to rehab, he can expect to regain full use of his knee, however it will take quite some time. His recovery will also be dependent on whether or not he encounters any complications such as nerve damage and muscle atrophy in the lower leg. Nonetheless, we can definitely expect that he will miss the rest of the season and we won't be seeing much of him on the field for at least 12 months.
The typical recovery timeline after ACL surgery is not a quick process. For the first 2 weeks after surgery, Robbie will be on crutches. He can then begin physical therapy after 2 to 4 weeks. However, full rehabilitation can take up to more than 6 months post-surgery.
Okay, well, sorry poor fans, it looks like one of your star players will be out for quite a while now. Doctor, how do you assess the severity of an ACL injury and what kind of scans would Robbie have to have done?
So to determine the extent of Robbie's injury, doctors would have to look at an MRI, or it is known as a magnetic resonance imaging scan.
As you can see on this sagittal T2 weighted MRI scan, an undamaged ACL has a void signal intensity and appears as a continuous dark band of fibres that take an oblique path through the intercondylar notch. However, a primary sign of acute ACL damage is a loss or interruption of this void signal intensity by regions of increased high signal intensity. These regions are indicative of edema and bleeding within the joint, and this is often due to a tear of the middle genicular artery. Furthermore, bone bruising may also be apparent on a sagittal MRI due to the subluxation that occurs with an ACL tear. Coronal MRI scans are also useful for visualizing an ACL tear, as the discontinuity of this ligament within the intercondylar notch of the femur is further evident. Lastly, depending on the severity of the anterior translation of the knee, a tear of the posterior horn of the medial meniscus may also occur, which is evident on an MRI scan by a region of increased signal intensity between the medial meniscus and the posterior aspect of the joint capsule.
Okay, well, a massive thank you to our special guests from the Port Adelaide Football Club's medical team. I hope you have all enjoyed this special injury segment of the footy show. Now on to some more footy news.